Alterations in fluid and electrolytes. Manifestations. Hypovolemia is the low volume of extracellular fluid, while dehydration is going to be a low volume of fluid in all compartments. So hypovolemia is basically a low volume of blood in our blood vessels, while dehydration is going to be a low volume of fluid not only in the blood vessels but also in the cells. Causes are inadequate fluid intake, fluid loss due to hemorrhage, vomiting, diarrhea, wounds, profuse urination, fever. And it's important to understand that with each degree of fever over normal, this can cause up to 10% loss of body fluid. Symptoms of hypovolemia or dehydration include a decreased blood pressure and/or postural changes in the blood pressure, that orthostatic hypotension, with decreased circulatory volume, oliguria, that low urine output, tachypnea, thirst, lightheadedness, dizziness, confusion or delirium. And with confusion, we never know what the cause of confusion is. This is just a side note. Always try oxygen first. The body's then going to try and compensate for this low fluid volume by increasing the heart rate to maintain that cardiac output. Hemoconcentration, or concentration of the blood, will increase the risk for deep vein thrombosis, those blood clots, and urinary stones. These clients are going to be very thirsty, and when we look at their blood work, we're going to see an elevated hematocrit and blood cell counts. We'll see elevated urine-specific gravity. And for example, with a lot of our electrolytes, we are going to start seeing an elevation in all of our electrolytes because the fluid is now concentrated. There's less of it, so all of the substances that are dissolved in it are now concentrated. How do we treat it? Well, medically, we're going to restore that fluid deficit by increasing the client's oral intake or administering IV fluids. For the older adult, we say 50 to 75 mLs per hour is going to be pretty normal. And we can go up to 100 or 125 mLs per hour, but that will be on the higher side. And we don't do that for an extended period of time in the older adult. 150 to 250 mLs per hour, this is going to be the rate that we would infuse for fluid resuscitation. In other words, we're replacing those fluids for the average adult. But on occasion, we're going to see 250 to 500 mLs for 1 to 2 hours. And again, that will be on the higher side. The nursing interventions will be to encourage the client to take in 8 to 10 glasses of water every day. Avoid caffeine beverages. Caffeine, if you are not aware, is going to cause diuresis. In other words, it will make us pee. Do not restrict sodium. Water follows sodium, so if the client takes in more sodium, they'll be able to hold on to more water. Encourage the client to change positions slowly. They have that orthostatic hypotension. We don't want them to get too dizzy or lightheaded. Be alert for symptoms of fluid volume overload with fluid replacement, especially in the older adult, as The older adult is not going to respond well to rapid fluid volume changes. So hypervolemia will be a high volume of water in the intravascular fluid compartment. Causes of hypervolemia include excessive fluid intake, heart failure, kidney disease or kidney failure, a high sodium intake, because once again, water follows sodium and causes the body to hold on to water, and an adrenal gland dysfunction. In these clients, we will start seeing weight gain, an elevated blood pressure, pitting or non-pitting edema. And if you look at your slide, the picture shows pitting edema. I would probably call this 4+ pitting edema. Dependent edema. Dependent edema is edema that is drawn by gravity. So it's going to be the part of the body that is the lowest. So if you're in a sitting position, that will be the feet and the butt. If you're lying down, it's going to be the entire surface that is touching the bed. So dependent is the fluid that will be drawn downward by gravity. We may hear those moist lung sounds, so crackles in the lungs. The client is going to begin having dyspnea because they have that fluid volume overload. Veins will be distended. Their hematocrit and blood cell count is going to be low because now everything is diluted because there's so much fluid. And the urine specific gravity will also be low. We're going to treat this by restricting oral or parenteral, meaning IV fluid, diuretics, and limit sodium. As a nurse, this is going to require us to do daily weights. If our clients are on diuretics, they will also be on intake and output. Then we're going to instruct our client on low sodium options for diet. We have a third type of fluid imbalance, and this is called third spacing. This is where the fluid becomes trapped in the tissue, and it can actually deplete the circulatory fluid volume. In other words, the volume that's in the blood vessel. So these clients can exhibit symptoms of hypovolemia, but there's no weight loss because that fluid is still there. It's just now in the tissues. It's not in the blood vessel. We may see fluid collection in the body cavities. We would call this ascites. The client may have generalized edema. The blood test may be normal, or they may exhibit the hemoconcentration, where we have that concentrated blood in the blood vessels. So everything is going to be elevated, just like with hypovolemia. We're going to administer IV fluids and do some colloid replacement, especially the administration of albumin. Albumin is the name for protein. This is going to help pull fluids out of the tissues and put it back into the blood vessels, that vascular system. And then once we get it into the blood vessel, we may administer diuretics. And I provide mnemonics to help you with the remembering of some of the terms and subjects we talk about. We have a client who's at risk for impaired skin integrity due to compromised circulation related to heart failure. The intervention to maintain intact skin includes changing the client's position every 4 hours, restricting ambulation, applying elastic stockings, or keeping the client's legs lower than the heart. This is C. We're going to apply elastic stockings. One of our treatments for edema is going to be the compression stockings or elastic stockings. This is going to help basically push that fluid back into the blood vessels. It helps prevent it from pooling. Electrolyte imbalances will occur as deficits or excesses. So we may have a low level or we may have a high level. And these are usually accompanied by fluid volume changes. Causes of electrolyte imbalances for a deficit, maybe we're giving IV fluids. The client is vomiting, has diarrhea, or is taking diuretics. Causes of excess electrolyte imbalances may include the client is taking these electrolytes orally. We may be administering electrolytes parenterally, in other words, through the vein. The client may have kidney failure. We have to realize that most substances will be excreted by the kidneys. So if the kidneys are not working, the body has a buildup of all of those items. And in this case, it would be the diuretic or the electrolytes. An endocrine dysfunction can cause an excess. Crushing injuries and burns can also cause an excess of electrolytes. Priority electrolyte imbalances include sodium, potassium, calcium, and magnesiums. Remember that our levels are going to be elevated if we have dehydration because it's going to concentrate the electrolytes. And they're going to be low if we have a fluid volume overload because those electrolytes will be diluted. So we'll talk about sodium. Sodium is going to be important to maintain the normal nerve and muscle activity. It helps regulate osmotic pressure and preserve acid-base balance, while its main role is to regulate and distribute fluid in the body. As I've said before in this presentation, sodium attracts water. Water follows sodium. So where you have high sodium, you'll have higher levels of water. The normal sodium range is going to be 135 to 145. And just as a reminder, you have that lab value located in Blackboard to help you remember what your normals are. So with hyponatremia, a low sodium level, causes include profuse diaphoresis. In other words, we're sweating a lot. We're diuresing, we're peeing a lot. We have a loss of GI secretions, whether we have a nasogastric tube down our stomach and it's suctioning those secretions out, or we have a drain, and a condition called Addison's disease. What we may see in the client will be mental confusion, muscular weakness, anorexia. This anorexia is what we call a lack of appetite. There's no appetite. We have elevated body temperature, tachycardia, and maybe even seizures. We treat it by administering food or fluids that are high in sodium. We may give IV sodium chloride. We may restrict fluids, and this is done, and this will be the oral fluid intake. We restrict the fluid to help concentrate that sodium and institute seizure precautions, which would include patting the rails, making sure that the client is safe. Hypernatremia can be caused by diarrhea, excessive salt intake, high fever, excessive loss of water, decreased water intake. These clients may be very thirsty. They have dry, sticky mucous membranes, and their urine output is going to be decreased, and they may have a fever. Medically, we treat it by improving the water intake. We may administer hypotonic IV solutions. This would be 0.45% sodium chloride, also known as 1/2 normal saline, or 5% dextrose. As far as nurses, we implement intakes and outputs, assess the vital signs, and talk about dietary restrictions or supplements. With a high sodium diet, very important for us as nurses to be aware of where we're going to find sodium. It is going to be in most of our condiments, such as our mustard, our ketchup, our soy sauce, etc. We find it in the majority of our processed foods. That's how it retains flavor and helps preserve it. A lot of our processed meats, especially our sausages and our porks, are going to have a lot of sodium. Most of our canned food is going to be high in sodium. It's really important to teach our clients to read labels. If it states less than 5% on the daily value percentage, then we consider it low sodium. We can also teach our clients to open up a can of, let's say, green beans, rinse it off prior to cooking it, and that will remove a great deal of the sodium. We should encourage our clients to use herbs or other garnishes to help season, and that will help decrease the sodium intake. Potassium. It is going to help maintain normal nerve and muscle activity in our bodies. Our normal ranges are 3.5 to 5.0. Hypokalemia, so low potassium levels, are caused by those potassium wasting diuretics such as furosemide. GI tract fluid loss, again from nasogastric suctioning, drains, or vomiting. Corticosteroids, IV insulin, and glucose. Just an FYI, IV insulin is considered an antidote for high potassium levels. Assessment findings. These clients may experience fatigue, weakness, nausea, cardiac dysrhythmias, and paresthesias. We're going to treat it by using potassium-sparing diuretics, foods that are high in potassium, providing oral potassium supplements or IV replacement. We never administer potassium by IV push. In other words, putting potassium in a syringe and pushing it into the vein. If we do this, we could kill our patient. However, we can administer potassium through an IV infusion, but it's going to be diluted and it will be slow. We have to dilute IV potassium. We're also going to dilute oral liquid potassium. So if IV potassium burns during administration in the vein, we understand that this means the IV infusion needs to either be slowed down or diluted further. With hyperkalemia, high levels of potassium, this is caused by renal failure. We are going to be excreting potassium through the kidneys. So if our kidneys are not working, we are not peeing, then our potassium levels are only going to get higher and higher. Maybe it is from potassium-sparing diuretics such as spironolactone. Too many potassium supplements. Diet sodas are very high in potassium. Crushing injuries, Addison's disease, or parenteral potassium salts. These clients are going to experience diarrhea, nausea, muscle weakness, and/or cardiac dysrhythmias. We treat it by decreasing their potassium intake, administration of insulin and glucose, Kayexalate, and we'll talk about Kayexalate next semester, but this is a medication called sodium polystyrene that is going to help us excrete potassium if our kidneys are not working. Peritoneal dialysis or hemodialysis can also help us get rid of extra potassium. So as nurses, we teach our clients about their medications and their diet. Potassium is easily obtained through a normal diet, but since it's not retained, we have to continually replace it. A lot of foods that include our potassium or are high in potassium include vegetables, dried peas and beans, bananas, oranges, and maybe potatoes. One thing I want you to be really uh, I really want you to remember about potassium is if our potassium level is too high or our potassium level is too low, this can potentially cause life-threatening cardiac dysrhythmias. That would include ventricular tachycardia, ventricular fibrillation, and asystole. So a high potassium, a low potassium. If it gets too high, too low, we could potentially have life-threatening cardiac dysrhythmias. This is something very important to remember. We need to monitor these clients' cardiac status. Chloride. A normal chloride is 98 to 107. Hypochloremia is a low serum chloride that typically occurs during the loss of sodium. Think about table salt, that's sodium chloride. Think about normal saline, that's sodium chloride. We frequently are going to see chloride bound with sodium. Hypochloremia is caused by vomiting and uncontrolled diabetes. Symptoms include a slow, shallow respiration, hypotension, muscle tremors, and twitching. Hyperchloremia is that high serum chloride, and it's usually associated with metabolic acidosis. Symptoms include a deep, rapid respiration, weakness, and/or a change in the level of consciousness. Calcium. Calcium is involved in blood clotting, the transmission of nerve impulses, and it will be regulated by the parathyroid gland. Hypocalcemia is caused by a vitamin D deficiency. Vitamin D helps our body absorb calcium. So if we have a deficiency, we're not going to be absorbing calcium very well. Hypoparathyroidism, burns, pancreatitis, corticosteroids, blood administration, intestinal malabsorption, and this is often the result of damage or inadvertent removal of the parathyroid during a thyroidectomy. Excuse me. These clients are going to experience tingling, circummoral paresthesias, in other words, numbness or tingling around the mouth, muscle cramps, a positive cough stick sign. This is where you tap the area right in front of the ear and it starts causing facial twitching. The Trousseau's sign, bleeding, and tetany. Tetany is going to be a prolonged contraction of the muscle. In other words, a prolonged muscle cramp. We're going to treat it by administering oral calcium and vitamin D, IV calcium. If we note symptoms of hypocalcemia, go ahead and perform the cough sticks or Trousseau's sign, and if that sign is positive, confirm it with lab and/or immediately notify the healthcare provider because this will become an emergent situation. Hypercalcemia is caused by parathyroid tumors. Multiple fractures. Why multiple fractures? Well, our bones are what uses and stores a large portion of the calcium in our bodies. And if we have fractures, that calcium is now released into the bloodstream. So now the levels in our blood are going to be high, which is what we're measuring, and it's hypercalcemia. Paget's disease, prolonged immobilization, chemotherapy agents, and multiple myeloma. These clients are going to start feeling that deep bone pain because that calcium is being removed from the bone and put into the blood vessel. Anorexia, constipation, polyuria, pathologic fractures. These are fractures that occur without injury. Kidney or urinary stones. Most of our kidney or urinary stones are made up of calcium. So if we have high levels in our blood, that can lead to kidney or urinary stones. Medically, we treat it with IV sodium chloride. We treat the cause. We're going to administer furosemide, corticosteroids. As nurses, we need to monitor for complications, do that dietary teaching, make sure the client is taking in plenty of fluids, and encourage fall safety. Magnesium is going to be involved in the transmission of nerve impulses. It also helps activate enzyme systems, including the functioning of the B vitamins. Our normal levels are 1.3 to 2.1. Hypomagnesemia is caused by alcoholism, which is the most common cause in the United States. Diabetic ketoacidosis, renal disease, burns, malnutrition, intestinal malabsorption, diureses, or prolonged gastric suction. Assessment findings include tachycardia, paresthesias, neuromuscular irritability, excuse me, hypertension, mental changes. Medical management includes oral or IV magnesium and diet supplements. Hypomagnesemia hypermagnesemia is caused by renal failure. Again, we're not excreting it, so our levels get too high. Addison's disease, excessive antacid or laxative use, and hyperparathyroidism. These clients will have flushing, hypotension, lethargy, bradycardia, muscle weakness, coma. It also causes some CNS depression, so our respiratory system can slow down. Medically, we decrease oral magnesium or parenteral replacement. These clients may require mechanical ventilation because of the slowed respiratory system. We need to monitor for arrhythmias, monitor the client's respirations, their neuromuscular irritability, and their blood pressure. We monitor the neuromuscular irritability by checking their reflexes. Phosphorus. A normal phosphorus is 2.8 to 4.5. Hypophosphatemia is caused by chronic starvation or malabsorption, often in clients with alcoholism, especially if we combine this with vomiting or copious diarrhea. Long-term ingestion of antacids, burns, starvation, and diuretics can also cause low levels. These clients have anorexia, muscle weakness, osteomalacia. This is the softening of the bones. And if you look at the picture on the slide, you see how those bones begin to bow outwards due to osteomalacia. Neuromuscular disturbances that would include progressive encephalopathy. This is going to be mental changes in the brain, and they are usually permanent. Seizures, coma, and death. We treat it with oral or IV phosphate replacement. Hyperphosphatemia can be described as high levels of inorganic phosphate in the blood caused by excessive dietary intake of phosphate. This can also come from laxatives or enemas, a deficiency in calcium or magnesium, severe infections, prolonged exercise with rhabdomyolysis. This is where the body is starving, so it begins to eat the muscle for energy, hormone problems, and kidney failure. Symptoms include elevated blood phosphate levels in addition to other electrolyte values, or there might not be any symptoms at all. Treatment will be identifying and treating the underlying cause, the administration of aluminum hydroxide or calcium carbonate tablets. So let's talk about the diet and the electrolytes. We've already talked about a few, but let's add a few more. So once again, foods that are high in sodium are going to be our processed foods, our canned foods. Fruit, even though it's canned, will have minimal sodium added, so it's not really considered high sodium. Those smoked or preserved meats and condiments. Again, if it's a canned food, you can rinse it off to remove extra sodium. Foods that are high in potassium. Again, fruits, avocados, spinach, potatoes or sweet potatoes, the acorn squash, salmon, and broccoli. Some of the fruits that are low in potassium would include berries, cherries, apples, grapes, and peaches. Foods that are high in calcium are going to be dairy, our dark green leafy vegetables, and salmon. Foods that are high in magnesium are going to be our seeds or nuts, spinach, avocados, figs, bananas, berries, and kiwi. Foods that are high in phosphorus will include chicken, turkey, organ meats, pork, seafood, dairy, sunflower and pumpkin seeds, whole grains, beans, and soy. So, which of the following interventions would be appropriate when caring for a client with hypercalcemia? Would we encourage fluids, promote bed rest, administer calcium supplement tablets, administer antibiotics? We're going to encourage fluids. We have a high level of calcium, so we want to dilute that level of calcium by increasing our fluid. And then a post-test.